So Dr. Philippe Lagacé-Wiens will be joining me shortly on stage to moderate the next session. Dr. Lagacé-Wiens is a medical microbiologist at Saint-Boniface Hospital in Winnipeg and an assistant professor of the Department of Medical Microbiology and Infectious Diseases at the University of Manitoba. He completed his doctoral degree and BSc in University of Manitoba and achieved his BC certification in medical microbiology in 2008. His research focuses on antibiotic resistance, molecular diagnostics, and tropical infections. Dr. Lagacé-Wiens holds a director position on the AMMI Canada Board of Directors and is an active member of the Canadian Antimicrobial Resistance Alliance, CARA. Participating in national surveillance studies and on multi-drug resistance pathogens, he has published over 100 works on clinical microbiology, diagnostics, and antimicrobial resistance, and was named the Clarivate's highly cited researchers of 2021's list. Thank you so much, and welcome, Dr. Philippe Lagacé.
Thank you very much, and I'm actually looking very much forward to this session, AMR Burden in Canada and worldwide, to give us some idea, as most of us are very aware already, of the burden of this significant problem. And it gives me great pleasure today to introduce my colleague, Yves Longtin, who is apparently in Geneva right now, to do a virtual session. Dr. Yves Longtin is an infectious diseases specialist and a medical microbiologist. He's the chair of the Infection Prevention and Control Unit of the Jewish General Hospital in Montreal. He is the current president of AMMI Canada, the Association for Medical Microbiology and Infectious Diseases Canada. Dr. Longtin's research interests involve numerous aspects of infection control, including, of course, the control of multi-drug resistant organisms.
Thank you very much, Philippe, for the introductions. And thank you for inviting me. I'm sorry I couldn't make it in person. I'm sadly out of the country today, and I heard the crowd is very interested and very dynamic. So I think I'm missing something by not being there in person. But I hope that I can still do a decent job remotely, even though I cannot interact with you directly. So over the next 20 minutes, I'll try to give you a perspective of what is the burden of AMR in worldwide and also in Canada, including forecasts about where are we heading, for example, in 2050, where are we going to be if we don't do anything about it. We're also going to explore some aspects about what we can do to control AMR, and also give you the perspective of AMMI Canada regarding what is our role in the fight against AMR. These are my disclosures. I have no relationship with the industry to declare. So I think we have to start initially by a few definitions. First things first, what is AMR? Well, AMR, we almost, see this almost as a synonym, as a bad thing. But we have to take into account that AMR, or antimicrobial resistance, is a phenomenon that occurs whenever a microbe, a bacteria, a virus, a parasite, no longer responds to antimicrobials that used to be effective against them. It is a natural process. So AMR has been occurring since the dawn of time. The problem is that it is accelerating right now because of the overuse of antibiotic and misuse of antibiotics as well. The consequences of this acceleration of AMR is that now antimicrobials can become ineffective that used to be effective. And some infections may be impossible or very difficult to treat. So when I say that it is a natural phenomenon, it is very interesting to remember that many of the antibiotics we're using right now, nowadays, actually come from the environment and have been around in the environment for sometimes hundreds of millions of years. So if these antibiotics have been around in nature for all this time, so is AMR has been around. And by some estimates, beta-lactam antibiotics and beta-lactamases, so the enzymes that destroy these antibiotics, have been around on the planet for over 2 billion years. So it is not a new phenomenon at all. One question also that needs to be clarified immediately is, what is a multi-drug resistant organism? And I think here we have to recognize that there's no single definition of MDRO. The list of microbes that we put on this list is constantly changing. It is a moving target. So experts continuously add new microbes to this list. I think that the new one that has been added recently is Candida auris, which is not even a bacteria. And others are constantly being removed. We used to be afraid of gentamicin-resistant enterococcus, for example, not so much anymore, or bacteria that produce extended spectrum beta-lactamase. This one is debated. Some people still worry about them, but some people are arguing now that we shouldn't care too much about these. Nevertheless, there are some bacteria that made broad consensus regarding their threat. MRSA, VRE, drug-resistant Acetobacter, or the new carbapenem-resistant Enterobacteriaceae, that's the gram-negatives, E. coli, Klebsiella, etc. What is the burden of AMR nowadays? Well, there's one key paper to cite and to be aware of. It was published in The Lancet in 2022 by the Antimicrobial Resistance Collaborators, which is a work group. And their goal was to quantify the burden of AMR from 204 countries. And for this, they extracted, or they had access to close to 500 million data points. So it's a massive undertaking. And they did two comparisons. They compare the impact of having an infection due to an AMR bacteria to no infection at all, and also compared the burden of having an infection due to an AMR bacteria compared to having the same infection, but the bacteria will not be resistant. That allows us to estimate the attributable mortality due to the fact that the bacteria is resistant. And their data is actually very striking. Overall, they estimate that 5 million people die every year of an infection that is due to an AMR bacteria. Now, keep in mind that some of these infections would occur in any ways but to sensitive bacteria. So the part of these 5 million deaths that are directly related to the fact that the bacteria is in AMR is 1.3 million deaths a year worldwide. This number is quite impressive because keep in mind as a comparator that nowadays HIV kills approximately 700,000 people a year worldwide, and malaria another 600,000 deaths a year. So AMR-related deaths nowadays is the equivalent of the combination of HIV and malaria deaths. How does this translate to Canada now? Because much of this burden is shared by low and middle income countries, less so by the developed countries. Well, we're able to extrapolate data from this very important paper and compare it with other causes of death in Canada. So if we look here, the top 12 causes of death in Canada extracted from Statistics Canada, based on this Lancet paper, we estimate that there's 20,000 deaths in Canada due to an AMR bacteria, and 4,500 of these are directly attributable to the AMR. So overall, those infections would really make this phenomenon one of the top 10 causes of death in Canada nowadays. And things are likely to get even worse. If we look at the forecast to 2050 in Canada, we see that the number of associated deaths and the number of attributable deaths will likely double between 2024 and 2050. By comparison, the population, the forecast in terms of increase in population in Canada, because we have to take this into account, is only likely to increase by 20%. So 20% increase in population, doubling in the number of AMR infection-related deaths in Canada, it is a very, very important and serious phenomenon. What we're seeing also is a change in the population that is being affected by AMR infections. Since 1990, what we've seen is an increase in the proportion of the population that is dying from AMR that is elderly, compared to a decrease in the proportion who are children or babies. So there's a change in the epidemiology of who is getting infected by AMR worldwide. One question that people often ask us to answer is, is AMR a problem of the healthcare system or the community? And there's many different ways to look at this. But I think one interesting thing to avoid having blind spots is to look at the CDC list of critical pathogens or threatening pathogens from 2019. It's just a list, and this list contains 21 pathogens or microorganisms. It is interesting to see that approximately half of these spread mainly in the healthcare setting, whereas the other half is mainly spreads in the community. So hospital bugs, CPE, VRE, MRSA, for example. But community bugs, let's look at Salmonella, drug-resistant Salmonella, or drug-resistant Shigella, or drug-resistant tuberculosis. These are pathogens that spread mainly in the healthcare setting, in the community, sorry. If we look, however, at the burden of AMR in the hospital system, if we look at the data from the United States, we see that the threat of AMR is very serious. If we look here at the top 15 microorganisms causing nosocomial infections in the United States, you have this list here, and you see that the top 5 is E. coli, Staph aureus, Enterococcus faecalis, Klebsiellas, and Pseudomonas. Well, 5 of the 5 top microorganisms causing HAIs in the United States are emerging threats in terms of AMR. And for the top 15, 9 out of the top 15 are emerging threats for AMR. Globally speaking, we can look at the GLASS surveillance system from the World Health Organization. Nowadays, 42% of all E. coli on the planet are estimated to be resistant now to third-generation cephalosporins. And globally, 35% of the Staph aureus on the planet causing infections are now MRSA. So preventing HAI and preventing nosocomial infections will be very important, because the situation can really change rapidly in some jurisdictions. And I think the poster child of this situation is what happened in Italy between 2006 and 2014 for Klebsiella that is resistant to carbapenem. In 2006, only 1% of all the invasive samples that yielded Klebsiella pneumonia in Italy were resistant to carbapenem, 1.3% only of the bloodstream infections. By 2010, it was 10%. And by 2014, it was 25% of the invasive samples that the Klebsiellas were resistant to carbapenem. So the situation can change in less than a decade in some jurisdiction if you lose control of the spread of these microbes. And this is what we need to avoid here in Canada. If you look at the data from Canada for carbapenem-resistant organism, for example, we have data available through the CNIS, the Canadian Nosocomial Infection Surveillance Program. The data from 2010 and 2022 shows that the number of isolates, both clinical isolates and isolates from colonized sites, such as rectal swab, has been increasing steadily. And we have the impression even that maybe it's following an exponential curve, not a linear curve, a linear relationship, which will not be very surprising for an infectious or a communicable disease. When we look at where does the acquisition or what is the source of these infections and colonization, well, what we see is that the main driver of CPE infections in Canada is not the community, it is the healthcare system. Either here you see the main drivers, either the nosocomial infections attributed to the declaring hospital for the orange line. The magenta line would be nosocomial infection acquired outside of Canada, but to a hospital outside of Canada. And the purple line, which would be nosocomial infections due to a facility in Canada, but not participating in the CNIS surveillance program. So the turquoise line, which is actually community-associated CP infection, is increasing, but you see that the vast majority of the increase is really due to nosocomial infections. What's the impact of all these infections? Well, that could be, I don't have enough time to go to all the details of the clinical impact of these infections, but let's look at just a few examples. Well, the clinical impact is that these infections are more dangerous, so they're more difficult to treat. They're associated with increased morbidity and mortality. They also require more resources. They're more expensive. They require the use of more expensive antibiotics associated with increased length of stay, increased resources in terms of infection control. And there's also collateral or derived problems coming from it, such as the drug toxicity if we have to use second or third line options that are more toxic to treat these infections. When we say that these infections are associated with increased mortality, I like to use this data from Patel in 2008 that compare attributable mortality when you have a bacteremia that's due to a Klebsiella pneumoniae and whether that Klebsiella is resistant or sensitive to the carbapenem. If the bacteremia is due to carbapenem-sensitive Kleb pneumo, overall mortality is estimated at 20% and attributable mortality 12%. But if that very same bacteremia is due to a Klebsiella pneumoniae that's carbapenem resistant, mortality increases to 48% and attributable mortality to 38% in that study. So this is what we're seeing. We're seeing people dying again of infections that used to be treatable. And that was the key message from Margaret Chan, who was the Director General of WHO in 2012, when she described the phenomenon of a post-antibiotic era, which is the time that we're living right now, where people start dying from infections that used to be treatable because we had antibiotics to treat them. The IDSA published a white paper in 2004, and I think the title is really apt, which was called Bad Bugs, No Drugs. And at the time, they were describing the problem that the pipeline was drying up. There were less and less antibiotics available to treat these infections. Here you see the number of antibiotics approved by the FDA between 1980 and 2012. And I think you see a clear trend. You don't need to be an epidemiologist to see the trend. What happened since 2012, however, in the United States is very interesting. They saw a rebound of new drugs who came on the market. Between 2010 and 2019, there were 17 new antibiotics approved in the United States. And some of them, such as ceftazidime, avibactam, have been approved since 2015, 9 years that they've been available in the United States. So the pipeline has reopened in the United States. The problem is it didn't follow in Canada. In this very interesting paper published by an international team in 2022, they have shown that out of the 17 antibiotics that were brought to the market in the United States, the majority of these were also approved in other high-income countries. Whereas in Canada, only 2 of these 17 antibiotics have been brought to the market. So there's a lag in terms of access in Canada. Another topic that I'd like to address is the antibiotic AMR arms race that is occurring continuously. And I really like this graph that shows that as we're getting stronger to defend ourselves, so are the microbes becoming stronger to attack us. And this arms race is a phenomenon that's occurring continuously. And I'd like to take one example so we don't lose sight of this phenomenon that we are repeating over and over again. VRE. VRE back in 1999 was very worrisome pathogen. There was no treatment available against VRE, and it was in the newspapers. You see here clips from 1999 from the BBC News that showed superbug, no treatment exists. But we stopped worrying about VRE. And why is that? Because many hospitals are not even now arguing that we should stop isolating patients who are colonized by VRE. So why did we stop worrying? Well, a hint, it's not because VRE disappeared. It's because new drugs were brought to the market, mainly linezolid in 2000 and daptomycin in 2003. The problem is that now we started using these drugs, and now we're seeing the phenomenon of linezolid-resistant VRE spreading in some hospitals in the United States. Let's remember that linezolid has a very, very low barrier to resistance. A single point mutation is sufficient to make a bacteria resistant against linezolid. And actually, when the drug was brought to the market in 2000, as early as 2001, the first linezolid-resistant enterococci were described. So how can we stop the spread of AMR? Well, quite obviously, you'll understand that we have to stop overusing antibiotics. Out of the 5 core actions from the CDC, you see that antibiotic use is one of the key corner criteria or core actions you can do to fight against them. The other things are better infection control, better surveillance, vaccines. Vaccine is interesting. For example, the RSV vaccine could help fight AMR. How is that? Well, simply because in the UK, for example, up to 10% of all the antibiotic use in the community is for infections that turn out to be due to RSV. The use of the RSV vaccine would prevent these infections and prevent the overuse of antibiotic. We also need better diagnostics. Without diagnostics, you may end up over-treating some infections. I think a good example would be a patient with fever in a sub-Saharan country. Is it typhoid? Is it malaria? We don't know. The patient may end up being treated for both conditions. We also need better environment and better sanitation, especially access to safe and clean water in LMICs. AMMI Canada is playing very many different roles, and I'm going to finish with that, many different roles to address the fight against AMR. We're publishing, working on guidelines, endorsing guidelines. We're working very hard in collaboration with CNIS for surveillance of AMR. Many activities also in terms of education, knowledge transfer, to educate the population and healthcare workers about the proper use of antibiotics. We're also very involved in terms of research groups, and also more and more collaboration with key stakeholders, and also advocacy now, where we're trying to advocate for increased workforce and also improve antimicrobial access. So it's all the time that I have, 20 minutes. I know it's a bit of a whirlwind presentation, but I hope you got something out of it, and I wish you a good rest of the meeting.